My name is Laura Bowers. I am a member of the board for Alamo Breast Cancer Foundation. And we are going to be talking today about immunotherapy and breast cancer. And for this, we're joined by Dr. Keith Knutson. He is a professor of immunology and cancer biology at the Mayo Clinic in Jacksonville, Florida. So welcome, Dr. Knutson.
Thank you. Great to be here.
Yeah, so did you want to add anything to your bio or anything else you'd like to share about your background?
No, let's dig right in. I think you're right on target. We do a lot of work, mostly in immunotherapy with respect to cancer.
Great. Yeah, so I kind of wanted to start off just a little bit general about immunotherapy in general, what it is, and how it differs from other types of cancer treatments like the traditional chemotherapy or other targeted therapies. Can you kind of describe for us what immunotherapy is?
Yeah, let's first think about, what the immune system is. I think over the past 2-3 years, we've all been faced with trying to understand the immune system and its capabilities and everything, particularly with the pandemic and the development of vaccines to block COVID. So the immune system is extremely complex. It's, it consists of multiple different cell types and proteins in the body that, swarm around the body and swarm around tissues looking for threats. And the threats could be, and most often are, microbes, viruses, bacteria, and your immune system does a good, job at getting rid of most of those before they, lead to an infection and cause some kind of disease or, some kind of pathologic response in the body. So the immune system can be basically thought as two different types of immune systems together. One is the innate immune system. So this is the rapid acting immune system. And this is what is up front every day, blocks microbes, and really does a superior job. If you didn't have that, you would always be getting sick. And then there's the adaptive immune response. So the adaptive immune response is a little bit different in that it's specific. And so we think about, for example, I'm going to put it in the context of, what we're all going through right now, and that's COVID. So when we, have a COVID infection, with SARS-CoV-2, your innate immune system doesn't block it in general. And it becomes, obviously an infection. And what happens is ultimately you have to activate what's called the adaptive arm of the immune system. And that becomes very specific. And so, for example, the vaccine that we use for COVID drives this adaptive immune arm so that you have very highly specific antibodies and T cells. Those are the two major types of components of the adaptive immune system, and that target the infection. The same is for cancer. And so we think about, immunotherapy of cancer. What we're trying to do is we're trying to activate the adaptive arm of the immune system so that you can get T cells and antibodies that are, specific for the cancer and can do their job. They can get rid of this, cell that is very abnormal, doesn't fit anywhere well within the body, and has the capability of, establishing, distant metastases and causing problems in various organs. And so immunotherapy is really meant to stimulate the adaptive immune arm in some way. Sometimes it's just giving that adaptive immune response to an individual. So T cell therapy, for example, is a type of therapy in which T cells are manipulated outside of the body and then injected back into an individual, and they go to the tumor site and can get rid of the tumor. So Immunotherapy refers to a vast array of different types of technologies that we're using to stimulate the immune system against cancer.
Gotcha. So, yeah, that's really interesting about being able to take out. So it's the patient's own T cells, and then they're manipulated and then infused back into them.
Right.
Yeah, correct. It's very interesting. So I wanted to ask, it seems like some of the early immunotherapy drugs worked really well for certain cancers like leukemia, but then there hasn't been that much success so far to get an effective therapy against breast cancer, or at least I know there's a lot of things in, clinical trials and stuff, but so far there's not been a whole lot of success there. Why was that? Like, how does breast cancer differ from some of the early cancer targets that had success?
Well, that's like the holy grail to try to figure that one out.
That's what we're all trying to figure out.
Right. We've had a lot of success with a wide variety of immunotherapies in liquid type tumors, leukemias, and lymphomas. And we had to have some success with solid tumors as well, particularly melanoma and kidney cancer. And we've developed a number of immunotherapies that, can at least in a subset of individuals, can, really completely destroy the tumor and, provide years of, survival to a patient that's had, one of these types of cancers. Yeah. So your question is good. It's like, what is it about these cancers and that are, the immune system, seems to be effective, or immunotherapy seem to be effective, as opposed to breast cancer, where we, haven't got quite as far. And let me just back up a little bit and talk a little bit about what we have for breast cancer. So actually, in reality, as I see it, we have, breast cancer was in fact one of the first cancers in which we had immunotherapies. And so, and that was argued early on, and that was with the drug called Herceptin, trastuzumab. So trastuzumab is a monoclonal antibody. Monoclonal antibodies are derived from the immune system, and then they're made synthetically in a culture dish, and we can purify these antibodies and put them in a vial and give them to individuals with HER2 positive breast cancer in this particular case. And at first we thought, well, the antibody itself is not, really, doing much from an immunologic perspective. What it's doing is it's coating the outside of the tumor cells with this antibody, and it's kind of shutting it down in terms of, blocking the signaling or the pathologic activity of the HER2 molecule. And then we recognized, following further research, that trastuzumab is in fact activating the immune system. It's activating components of the immune system that lead to an attack by cells that are part of the immune system on the tumor. And so the reality is immunotherapy for cancer goes all the way back to, the 1990s with the development of Herceptin. Yeah. And then we have also, but that's just, of course, a subset of cancers, and it hasn't been really effective or quite as effective for cancers that have lower levels of HER2 expression. Gotcha. So then there was the development of another kind of immunotherapy, and that is like anti-PD-1 or anti-PD-L1 or immune checkpoint blockade. And that particular type of immunotherapy is more general in the sense that what it's supposed to do is kind of release the brakes on an already existing immune response against the cancer. And that's what it's supposed to do. And so in melanoma, for example, it's very interesting. So these types of tumors melanoma has an existing immune response that's already trying to tackle it. But what happens is these tumors upregulate a molecule called PD-L1 in the tumor microenvironment, and that suppresses the T cells and the antibody response that's already existing against the melanoma. And so, these drugs like anti-PD-1 or anti-PD-L1, we know some of the names like pembrolizumab or nivolumab have been very effective in melanoma because of that pre-existent immune response. So in triple negative breast cancer, we now use pembrolizumab. So we give that both in the setting of metastatic disease as well as in kind of the neoadjuvant and adjuvant setting in triple negative breast cancer. It can work much better. There's no question about that. It does provide for, some survival benefit, but it can work much better. And so for those subsets of cancers that it works well for, triple negative breast cancer, as opposed to HER2 positive breast cancer or estrogen receptor positive breast cancer, there's a pre-existent immune response that these drugs activate. And so breast cancer tends to be colder, and this is in the literature that they have this hot and cold tumor kind of dichotomy. It tends to be, breast cancer tends to be colder in terms of this pre-existent immune response. And so we need ways to stimulate that immune response against the cancer for these kinds of drugs to work. So in general, cancers that have more of an immune response benefit more from immunotherapies than those that don't. And so there's a lot of activity now in industry and in laboratories where there is evaluations or discovery or development of strategies to boost specific immune responses against breast cancer so that these drugs like anti-PD-1 or anti-PD-L1 can work better.
So is the anti-PD-L1 use in triple negative breast cancer, is that because it has a more immune response than other subtypes of breast cancer, or?
That's right. That's right. So what we know from our studies of breast cancer is that there's quite a variation in terms of the levels of what we're calling pre-existing immunity. And so in breast cancer, we see a wide variation, and it's those tumors that have more of these, pre-existent immune response against the cancer that fare better. And it turns out that triple negative breast cancer is a subset that tends to have more, immune activity already on board.
Gotcha. Makes sense. So I know there's a lot of activity or a lot of research in this area, around breast cancer and different immunotherapies. I guess and I think you kind of answered this to a certain extent already, but how do these newer approaches differ from earlier treatments? Is it more that they're trying to boost the immune response in the tumors to make them more effective, or are there other techniques or approaches?
Yeah, that's a great question. So, the pathway forward, I think that many groups and companies are interested in is trying to develop combination approaches. So it's just adding more fuel to the fire, so to speak, in terms of activating the immune response. We know that a very strong immune response against tumors can completely eliminate the tumor. We've seen it time and again in animal models that, of cancer, in which we give them immunotherapy, and we see that, the tumors shrink. We see it, it's very provocative in some patients that they, have complete resolution of tumors, or at least partial resolution of their tumors with immunotherapy. And studies that we, in mouse models and other models of cancer where we test new cancer agents, would suggest that we need to maximize the immune response, and we need to come in from multiple angles to maximize the immune response, not just one. So pembrolizumab or nivolumab, anti-PD-1 or anti-PD-L1, kind of captures one arm, of the immune response. There's multiple arms. And so we need to have combination therapies that, can really improve outcomes by stimulating, very vigorous immune responses.
Gotcha. So, I think we discussed this already. The current immunotherapy is the only one, the one for the triple negative breast cancer that's currently being used in the clinic.
Right.
Right. Okay. And how well does that work? Is it had good results?
Yeah, there definitely is. I wouldn't call it a home run by any means. But
room for improvement.
So how this is approved, of course, is, there's a couple of different ways in which this was approved. So it was used in the metastatic setting, of course, at first, where it was, given to individuals that had metastatic tumors, and it was evaluated for, number one, does it shrink tumors? And number two, does it provide a survival benefit to patients, right? And so those studies looked at progression-free survival and overall survival. And what they found is that individuals that were given, these immunotherapies that had triple negative breast cancer metastatic disease lived longer, not where we want to be, obviously. We want to be, at complete cures and, eliminating the cancer altogether. But it was a significant improvement in progression-free survival and overall survival in patients with triple negative breast cancer. And in the second setting, it was used in an earlier stage disease. And so, I think, many of the people that would be, watching this would know that there's multiple stages of breast cancer. This has, been around for many, many years. There's very early, stage 1, stage 2 breast cancer. And then there's more advanced breast cancers like stage 3 and stage 4. So pembrolizumab was used actually in clinical trials in individuals with earlier stage triple negative breast cancer. And what it was, and it was used in the neoadjuvant setting, so it was given before surgery. So, which is the common approach for of course, treating earlier stage disease is surgery and chemotherapy and other types of targeted therapy. So it was given in the neoadjuvant setting, so that means before surgery. And what was found is that it improved the response rate. So what we're looking for in neoadjuvant therapy is complete elimination of the tumor at the time of surgery. And we know that those individuals that have complete elimination of the tumor at the time of surgery tend to have very better, much more longer survival and less complications in the future from breast cancer. And what the addition of Pembro to neoadjuvant therapy did in these patients is it increased the number of patients that actually had a complete elimination of the tumor prior to surgery. And so that was very strong evidence that the immune system, is playing an active role, early in the course of disease and can be activated with immune-based therapies. And so then it's given after surgery for, many, many months to individuals as a single therapy, pembrolizumab, sometimes in combination with other therapies as well. And those individuals that had complete elimination of their tumor, and even those that didn't have complete elimination of the tumor, when they were given Pembro before surgery and after surgery, they had better recurrence-free survival, which means that they lived longer without having their cancer recur after conventional therapies. And so, it was an improvement and it was statistical, but we have a long ways to go in terms of, making it better. The approvals were based on, rather, modest increases in overall survival and progression-free survival.
Gotcha. So to kind of shift gears just a little bit, your current work is, I believe, mostly focused on cancer vaccines. Is that correct? I was just thinking, most lay people think of a vaccine as being, against an infectious disease. And how do the cancer vaccines differ from that more like traditional type of vaccine? How do they work?
Yeah, that's a good question. So, I think it's important to learn what the differences are. So when we have an infectious disease, our favorite one over the past few years has been COVID, and there's also, the flu. The idea is that we can give vaccines to prevent infection or prevent the deleterious effects of an infection. And so oftentimes vaccines can, do a good job of eliminating, or completely reducing the risk of developing a pathologic infection. And sometimes, the infection still occurs, but because you have an immune response, you get over whatever it is, the disease, much more rapidly and without extensive complications. And so that's typically how vaccines are given, is prior to exposure to infectious diseases. That's not how we use them in cancers in general. We use them in a couple of different ways. And in fact, I like to think about this as dividing up into three ways. The first way is that's a therapeutic. So vaccines do the same thing that for cancer, do the same thing that vaccines for infectious diseases do, in that they stimulate T cells and they stimulate antibodies in the individual that fight the tumor. So in the therapeutic setting, which is the first setting, we're trying to, give a vaccine while a tumor is already in a patient, and we're trying to activate the immune response, and we're asking the immune response to attack the tumor. So that's the first way that they're being used in cancer. The second way is more like prevention from relapse. And so we know a lot of individuals with breast cancer can be, cured or at least the tumor is completely eliminated in an individual with neoadjuvant therapy, surgery, and then adjuvant type of chemotherapy. So our goal has been to use that, setting, so to speak, clinical setting of no evidence of disease to stimulate the immune system so that you have T cells and antibodies floating around in your body looking for any recurrent tumor cells that start to develop and form a tumor. So that's the second way. There is a lot of interest in developing vaccines for primary prevention too. That's the third way. So primary prevention is much like in the clinical setting of infectious diseases, where we're trying to prevent the infection. In this particular case, we're trying to prevent the disease from occurring at all. So we're just starting to use vaccines in the prevention setting. Now, that doesn't mean that vaccines haven't been effective in preventing cancer. We know that human papillomavirus causes cervical cancer and head and neck cancers. And we do know now that the cervical cancer vaccine which is an HPV vaccine, can eliminate or reduce the risk greatly of developing cervical cancer, head and neck cancers. So in a sense, even though that particular vaccine, the HPV vaccine, is targeted at a virus, it actually can prevent cancer. Now, for something like breast cancer, we haven't been able to find a virus that causes breast cancer. Now, that doesn't mean that one doesn't exist, but we don't have, really the good associations that we have with HPV and cervical cancer, or hepatitis B virus and liver cancer. And so we have to, develop alternative strategies for targeting the immune system, because we can't target a viral protein with our vaccines. And so we've turned our attention to a couple of different strategies. The first strategy is to target proteins that are normally presented in the body, normally produced in the body, but that are so highly overexpressed in the tumor that your immune system is going to see that as foreign. And so, for example, we have a HER2/neu vaccine, which is very effective in generating HER2/neu or specific T cells and antibodies. And we're hoping that we can give that to individuals following their treatment of their disease to prevent the disease from coming back. Now, a second way, so that's targeting self-antigens. And this has been an approach which has been very effective in a few other types of cancers, and which is moving forward in the adjuvant or maintenance-like settings. So we're trying to prevent the disease from coming back. The second way that we are developing vaccines is through sequencing of DNA and RNA from an individual's tumor. And so this is an approach that has really gained in popularity and feasibility over the past 10 years, given the ease at which we can sequence somebody's DNA. So we can, just for a few $100s, we can sequence your entire genome. Well, we can do that in a tumor too. We can sequence the entire genome of a tumor. And what we find when we sequence is that there's a lot of mutated proteins. And your immune system can recognize those mutated proteins. And so what we're doing now is we're, sequencing the tumor DNA and RNA from individuals with breast cancer and developing vaccines that target the mutations. And that way we eliminate any cross-reactivity with proteins in other tissues in the body. So at least we think, we still need to test this more aggressively, that it's going to be a safer approach than, potentially targeting these self-antigens. Now, having said that, you can carefully construct self-antigen vaccines so that they don't cause toxicity. In fact, we haven't seen any toxicity with the vaccines that we've developed, but we also need to be cognizant of what we're targeting and how we target that. So it's, something that we still continue to work on. Vaccines targeting self-antigens are safe and have been safe due to careful construction of the vaccine. But now with these new ways of sequencing RNA and DNA from a tumor, we can individualize vaccines that we feel can be very robust in generating immune responses and target antigens specifically in the tumor with T cells and antibodies. So we're really excited about the future of being able to employ these new types of vaccines, which are just emerging.
Very interesting. So in talking about like the vaccines for primary prevention, how would you go about developing something like that? Like what would you, since they don't have cancer yet, what do you target?
You're right. So the way that we, great question. So the way that we target cancers that already exist is, we can stain them. I mean,
Right.
tumors get stained for HER2/neu, and we can see the HER2/neu on the tumor. And so we can say, well, let's, use a HER2/neu vaccine. But you're right. We, don't have the capability to know what kinds of cancers will develop in the vast majority of people. Now, in individuals with BRCA1 and BRCA tumors, we, know that they'll develop breast cancers that have like more of a triple negative breast cancer phenotype. But for the several 100,000 women that develop, breast cancer every year in the United States and across the world, we have no clue what they're going to develop beforehand. And so we need to develop vaccines that target multiple proteins that span the array of different types of breast cancer. We tend to, really generalize those into ER positive, HER2/neu positive, and triple negative breast cancer, but there's, multiple subsets. And so we're crafting, our group and other groups are crafting what we call multi-antigen vaccines. And so if you take something like the COVID vaccine, that targets one protein that's present in the virus called the spike protein. The vaccine that we're using for primary prevention of breast cancer targets several proteins. In fact, it targets 6 different proteins that get highly upregulated. And so what we've done and what others have done in other laboratories is construct unique genetic type vaccines. And this is very similar to, like an RNA vaccine in which we can stimulate T cells against multiple antigens. So you would have, in fact, all kinds of T cells in your body all the time running around that are looking for all these different antigens. And the idea is if a triple negative breast cancer pops up, you're going to have immunity that's going to be effective against triple negative breast cancer. If a HER2/neu positive cancer pops up, you're going to have immunity. And so we have carefully constructed this vaccine to target all of the major subsets. And actually, we're working with it was actually this particular vaccine that I'm referring to was actually driven by an advocacy organization, the National Breast Cancer Coalition, which is a coalition, a large coalition of advocates that have many different roles and responsibilities in terms of driving research and legislation in breast cancer. So they were behind the development of the breast cancer vaccine that we're working on getting into the clinic. And so they and we've partnered with them to make this happen. And that's going to be the big challenge for us is how do we make that happen? Do we give everybody the vaccine, or do we, try to identify individuals that are at high risk? And as you know, the risk models aren't perfect. And we need better ways of identifying individuals at risk. Now, we could say, well, what we're going to do is we're going to vaccinate BRCA, carriers. But that's a significant challenge. There, isn't as many as we would like. I probably didn't, put that in the right way, but there's not as many individuals that are BRCA that we can immunize that we can follow for long periods of time. And so that may be a challenge, is to identify, all these BRCA, carriers, and then only choose those ones that don't decide to have like a mastectomy or something like that to move forward with a vaccine. And so I think that the approach that we're going to have to use after we test the vaccine initially, in order for us to determine if it's going to work, is to really have a good risk model, something that we know can accurately identify the risk. Because what we need to do is we need to be able to measure events. And what I mean by events is we need to measure breast cancer, right? So with the COVID vaccine, we measured infections with breast cancer. We have to measure breast cancer. And so we need to make sure that we can measure breast cancer in the population that we choose to get the vaccine. And so if we have 10,000 women that are at very high risk, and we know that, 500 are going to get breast cancer over the next 10 years, then we can choose those, a similar group of women, and we can immunize those. And if we see 100 rather than 500 developing breast cancers, then that would be a home run for us. That would say, wow, we eliminated 400 cancers out of these 10,000 women that would have, that were at high risk. And so you can see that it becomes, it's like a numbers game. So we have to have a lot of people on board, and we have to understand the risk of developing breast cancer. Because if we just gave it to everybody, all women, and we know that women in general have a high risk of developing breast cancer in the U.S. But still, we would have to immunize tens of thousands of women and follow them for 10 or 20 years, and this is really difficult to do. It's really difficult to do, and so we need to have ways of identifying who is at high risk and put those onto those individuals onto study, and follow them for whatever time that we determine would be best to determine if the vaccine has efficacy.
Yeah, I think we should talk about some of the specific cancer vaccines that you've been working on. I know there's the HER2 positive breast cancer, the vaccine for the HER2 positive breast cancer. Where are you kind of phase-wise in that research?
Yeah, that's a good question. So, back 15 years ago, when 20 years ago, time flies so fast, as you know, but back about 20 years ago, our initial approaches to vaccination were to use those in patients that had heavy disease burden, and we realized that vaccines weren't going to be useful in that setting alone. So recently we've shifted to the adjuvant setting, so the maintenance setting, so to speak. So when an individual is treated, they have, no disease that we can detect, and they're all healed up. They don't take chemotherapy anymore. We can enroll them in clinical trials in which we try to stimulate the immune system with a vaccine, and then we can follow them. And we have 2 phase 2 clinical trials right now, one in triple negative breast cancer that has 290 patients enrolled. And a fraction of those have received placebo, because that's the only way we can tell if the vaccine works, is we have to have a placebo arm, but nobody knows who's on the placebo arm because it's blinded. And so I don't even know that. And those patients are now being followed, and we'll follow those for another 3 years. And the hope is, based on our statistics, we'll be able to determine whether or not this particular vaccine may be useful for preventing at least some triple negative breast cancers from recurring. Because as you know, triple negative breast cancer is one of those breast cancers that tends to recur at a relatively rapid rate. Now, the other vaccines that we have, like the HER2 vaccine, is also in phase 2 clinical trials. Now, that particular vaccine is being administered with TDM1, which is a conjugate of a drug with trastuzumab, which is the Herceptin-like molecule or antibody. And so individuals after conventional therapy, conventional neoadjuvant therapy, are offered adjuvant therapy for a period of time. And oftentimes in women with HER2 positive breast cancer, that's TDM1 that they're being offered. And so they're given TDM1 for, many cycles, and it's during that time period that we want to stimulate the immune system. So we have a phase 2 clinical trial in which we're testing this novel HER2 vaccine in HER2 positive patients, and the hope is we can prevent even more so than TDM1 alone disease recurrence in the HER2 positive patients. So we have 2 phase 2 trials in which we're testing HER2 vaccine in HER2 patients and triple negative breast cancer vaccine in triple negative breast cancer patients. And we don't want to stop there. Of course, what we want to do is we want to be able to also evaluate vaccines for ER positive, because as you know, ER positive is the vast majority.
Right.
And so this is a challenging situation because ER positive cancers tend to recur much later than triple negative or HER2/neu. So there's going to be a lot of follow-up time in those individuals. We don't have a vaccine for them yet. We're hoping that our new platform on immunizing against what we call neoantigens or mutated proteins in the tumors will be an effective approach, but we haven't gotten that one off the ground. We have some other vaccines that are early in phase 1, including the prevention vaccine that we're testing as well. So there are across the board, not only in our lab, but in other labs as well, vaccines that are being tested in phase 1 and phase 2 clinical trials for prevention of disease recurrence in individuals. Now, with the development of immune checkpoint blockade, so that's anti-PD-1 or anti-PD-L1 again, we now have opportunities to test it in combination with those drugs in triple negative breast cancer. And so we're exploring different options. So the idea is that, we can think through the problem, we can develop the vaccines, we have a way to test those vaccines, and the hope is that at least some of those vaccines then would ultimately go on to phase 3 clinical trials. Now, remember, in phase 3 clinical trials, you need a larger number of patients. You need to do it at multiple centers. It needs to, look like something that you could administer, in the clinics and clinical settings at home, where individuals live, and protect them from disease relapse. And so, so that's where the field stands in our laboratory anyway. We're in phase 1 and phase 2 clinical trials.
So how, if you had to estimate how long it would be until, some of these vaccines reach the clinic, like, can you anticipate that, or is it?
Well, I anticipated your question. That's because, this is a question that I'm always asked, and rightfully so.
Yeah.
Breast cancer impacts the lives of, hundreds of thousands of women in the U.S. Every year, not just the diagnosis of breast cancer, but, as it steals part of your life away. I mean, you not only the physical maneuvers of going to the doctor and removing the tissue and, having scars or having complications from chemotherapies, et cetera, you worry. And really that steals part of your life too, is you worry about, having to, deal with a recurrence, and you worry about not having the tools or the methods that you can use to help prevent the disease. I mean, we know some things are useful, like, great diets and staying fit and everything for recurrence. But, there's not a lot of tools. And so, so we need to do something, it's going to be, several more years before we see anything in the clinic. And we need to support the activities of, those that are, developing vaccines through grants, through other types of funding opportunities, so that we can keep testing. We need to be able to keep testing. And this is going to be very important, because just like any disease setting, we need to keep testing drugs that are well thought out, well rationalized in phase 1 clinical trials and phase 2 clinical trials, so that ultimately we can identify one that is going to make its way to a phase 3 and be approved. But it's going to be several years before that can get done. Even at the earliest, I would say 7 or 8 years before we may have some insight as to whether a vaccine is going to prevent disease recurrence in breast cancer.
Mm-hmm. Gotcha. One other question I thought of, so if a vaccine that's intended to treat active disease versus one that's for prevention of recurrence or prevention, primary prevention, would there be differences in sort of the formulary for that, or how it's structured, or is it essentially the same vaccine that you would be using in all those instances? Does that make sense?
Well, it may be different. Mm-hmm. So fundamentally, from an immunologic perspective, the goal is to generate antibodies and T cells, and we develop a format that we can inject into an individual. Their immune system sees that vaccine, develops the T cells and B cells against it, and from a theoretical perspective, there may not be any difference between mm-hmm. a vaccine for primary prevention and somebody that has active disease on board, because the overall goal is the same. Now, having said that, with the development of new technologies, and what I mean by that is the sequencing and the ability to interrogate the tumor microenvironment, we have more options for individuals that have cancer. In terms of understanding the types of immune responses we can generate. There's all kinds of different types of immune responses. So, there's certain types of immune responses that benefit an infection in the gut versus an infection somewhere else. And so, so there may be opportunities to personalize or change or alter vaccines so that or use them in combination with other things based on what we find out from the tumor itself. Mm-hmm. And so from a theoretical perspective, there's not that much difference. From a practical perspective, we have more information from an individual that already has tumor because we know what's going on inside their tumor.
Right. Okay. Just one more thing. So if patients were wanting to try to find clinical trials that, may fit their situation, what's the best place to look for those, like online or?
Yeah, so there's lots of big centers that, provide clinical trials. And many people live close to, not everybody, but close to one of these centers. So, in of course, Jacksonville and Phoenix and Rochester, Minnesota, we have the Mayo Clinic, and you can call, to the operator at the Mayo Clinic and they can direct you to the appropriate place. So a lot of these centers have multiple diseases that they deal with, cancer being one of those diseases. So the operator would be able to, tell the, or patch them through to the cancer center, for example, or maybe something like MD Anderson in Houston. So it depends on where you're at, and calling your, regional academic center that performs clinical trials would be a benefit if you're interested. There's also a government website. And there may be a little bit of a learning curve in terms of using it, called clinicaltrials.gov. And so that's a website that we all have to list our clinical trials on, and we're all assigned a clinical trial number that's listed on this. And so you can go in there and you can type in keywords that, are linked to your disease. So triple negative breast cancer, you can type in HER2 breast cancer, metastatic, or something like that, and it will pop up a list of different clinical trials, and it also provides the location of those clinical trials. And so whether or not you as an individual, you would be eligible for one of those clinical trials is unknown until you look at the eligibility, which is oftentimes printed along with other information on the website. But you can always pick up a phone call or you pick up the phone and call, the center that, is conducting this clinical trial and say, can I get more information about this clinical trial? What we know is that that individuals that are participate in clinical trials live longer, healthier lives than those individuals that don't. These clinical trials, are, typically well rationalized. They're vetted through scientific and safety, communities like the FDA, for example. So they're all, bona fide, well rationalized therapies that are developed for a particular disease. A lot of times they're very effective. There's a lot of reasons why one therapy or another may fail ultimately in getting FDA approval. That doesn't mean it's not an effective drug. It just means that the way, it could mean that the way it was tested was not an effective way to test the drug. And so, but what we know is that clinical trials have benefit to patients with cancer and should be explored through either interactions with your own physician who may have access to clinical trials, or your regional academic center that conducts clinical trials, or the website at clinicaltrials.gov that will help you identify a trial.
Sounds good.
That the end goal is sometimes you have to reach out for that information yourself, right. But the reward is that you'll have better, typically individuals, as I said, have better quality of life and longer life and a healthier life if they participate in clinical trials.
All right, I think we're about done. I really appreciate you talking with us today. It was really, really interesting.
Yeah, and I just want to add that advocacy plays a big role in driving research too. And so it's, very important that we all work together to, try to figure out ways to eliminate breast cancer. It's, it's a disease that costs us, hundreds of millions and perhaps billions of dollars every year in the U.S. and we should be doing something more or something else with those resources. So let's work to end breast cancer.
Yes, sounds good. All right. Thank you so much.
Thank you.
Bye-bye.